Good morning. I am Matthew Hart, CEO of Longwoods Publishing, and we are pleased this morning to have Sinai Health Systems hosting this morning's event, Breakfast with the Chiefs. Today's supporters, as you know, we cannot do these events without the support of our partners, and supporting today's event is the Canadian Foundation of Healthcare Improvement. They've been a great supporter of ours for years, and we look forward to their continued support and working with us. As well, we are also welcoming for the first time Schulich School of Business, York University Executive Education Center as a partner. They have generously helped to support this event today. In fact, I believe Robert Lynn is in the audience. Robert, over there. Robert Lynn is the Associate Director of Organizational Learning. Thank you, Robert, for working with us on this morning's event. If this is your first time here at Breakfast with the Chiefs, we have about a 40-minute presentation or so, and then we have some time for some Q&A. But that's enough from me. We are out of here at 9 o'clock in the morning, and without further delay, Michael Gardam.
Very much. Thank you very much. I'm just going to get my slides up here. Turn this on. Yes. There we go. All right, so I'm not going to wander too much, but I hate standing behind the podium. Hey, Leah. So thanks very much for inviting me here today. I'd really like to thank Longwoods and Schulich for suggesting that I come and present on this topic. Change is something we hear in healthcare every 30 seconds, how hard it is to get people to change, that people are afraid of change, et cetera, et cetera. And so I thought it would be fun to give you a talk on some of the work that I've been doing with some colleagues at UHN over the last 5 or 6 years. And this ties in nicely with a paper that's coming out in Healthcare Papers with Longwoods later this fall. So what I'm talking about today, you'll be able to read in an actual journal if that interests you. I want to start off with a question. How many of you have gone to a conference, heard something really cool, and want to bring it back to your organization? How many of you have brought it back to your organization and you're like, holy crap, this is such a cool idea, and it's just like not going anywhere? How many of you have experienced that? I certainly have. So this talk is all about that moment when you've got a cool idea. How do you bring people along to actually bring about change? Because I would argue that our world of patient safety and quality improvement is full of stories like that. There's something amazing that happens somewhere, but you're not able to do it here. Just as a, whoops, why is it doing that? That's cool. Okay. Just as a real-life example, many of you will know the paper in the top left-hand corner, which was a New England Journal article about the safe surgical checklist. And that was done, it was an international study, showed quite a dramatic reduction in adverse events in the operating room. Kind of made perfect sense. It's a very logical tool that, you know, everybody should get behind. It makes really good sense why you should be introducing yourself to the patient, why the team should be introducing itself, why you should be going through all the things, making sure you're operating on the right body part, et cetera, et cetera. And then we made these mandatory in Ontario for very logical, intelligent reasons, and it didn't work. At least not initially, it didn't work. And that was a follow-up New England Journal paper that showed that there was some problem with the translation between a really good study and actual practice. So this kind of thing happens a lot. And that's an area that my colleague Leah and I have really tried to focus in on. What is it about that, and how do we change that problem? Here's the problem. Culture eats strategy for breakfast. Now, when you Google this and try to figure out who said this, it turns out everybody says this. There's actually no one person who ever said this. But it really is true. And I'm going to tell you a bunch of stories from my own career where I really messed things up. Because I thought something that was logical we should just do, and then realized afterwards that that actually wasn't going to be the case. I want to talk about hand washing as an example. And I'm not going to spend the next 45 minutes teaching you how to wash your hands. You can all stay in the room. It's going to be okay. All right? So we had this little cartoon commissioned by Public Affairs at UHN because it was exactly how we felt about hand hygiene. You've got your tools, your education, you've got your audit things, you've got your reminders, your posters, and then you smack into culture. And so about 8 or 9 years ago, we started out as part of Ontario's Just Clean Your Hand program to try to create a hand hygiene program at UHN. And Leah was actually in charge of that. Do you want to wave, Leah? People can see who you are. She loves it when I do that. Leah was in charge of that, and it didn't go well. It wasn't Leah's fault. It was, we really struggled with that. So we had these standardized posters and standardized ways of doing things, and we had some trouble with the posters. People actually hated them. We got a lot of complaints about them, et cetera, et cetera. We tried to do a number of things to improve hand washing. One particular thing I loved was at Cedars-Sinai in LA, the chief of medicine was handing out Starbucks gift cards to doctors if they cleaned their hands. And I read this in the Wall Street Journal, and I thought, oh my God, that is genius. So just go back to the conversation we had 5 minutes ago. Here's an outside idea that I thought was really cool. I'm going to bring it to UHN. But of course, we're going to hand out Tim Hortons gift certificates because this is Canada, and it's a lot cheaper. So we had these Tim Hortons gift certificates. I think I spent like $2,000 on them. And if I saw you cleaning your hands, I would give you a Tim Hortons gift certificate. And people kind of thought it was weird and kind of strange, but some people liked it, but not everybody liked it. Jill will remember this. There was a letter written to the Globe and Mail saying, what the hell, we're bribing healthcare workers to do something that's obvious they should be doing. And we ended up getting into some trouble with that, so much so, they actually did an editorial cartoon on it, which is basically a nurse who's so hooked on Tim Hortons coffee that he no longer has any skin on his hands. The letters to the editor came pouring in, et cetera, et cetera. It's a good example of something that worked elsewhere that didn't translate well when it came somewhere else. So this is a quote from one of my favorite business books called Sorry I Broke Your Company. And it's written by a former consultant who would go into organizations and would give them the best practice documents from other places and then try to drive change to force people to follow these things. And as Karen Phelan says here, we've been taught that businesses are logical, but they're people. They're irrational, emotional, unpredictable, et cetera, and you get in the way of that sort of long-standing machine model of business, or I would argue hospitals, where we should all be exactly the same and we should behave in exactly the same way. You run into problems there. So one slide on sort of complexity theory. So the work that Leah and I do is based on complexity science. And basically that world divides the problems that we face into 4 categories. Simple problems, complicated, complex, and chaos. We're not going to talk about chaos because we really don't experience that in our world, although we think we do. I'm really going to talk about simple, complicated, and complex. Now on this curve, they're basically divided up according to 2 axes on how much agreement there is in the room and how much certainty that any one approach is going to actually get you where you want to go. So in circumstances where you've pretty much got consensus and everybody knows the way forward and you can kind of see how that's going to work, those are simple or complicated problems. In circumstances where you kind of look at it and go, I have no clue how we're going to fix this problem, and there's ideas from all over the place on how to fix it, that's a complex problem. The whole point of this talk is that the approaches you use for complex problems are different than the ones you use for simple and complicated. Unfortunately, we like simple and complicated problems, and so we try to stick the square peg in the round hole all the time, and then we can get ourselves into difficulties by doing that. So the examples we give, and these examples come from my mentor, Brenda Zimmerman from York University, who died a couple years ago, and who really, I still have a hard time even talking about it because she was so important in this world for the work that we do. Simple problems like baking a cake. Follow the recipe, you get a cake. No surprises. It may not be a perfect cake, but the more you do it, the better you're going to get at it. Complicated problem might be like sending a rocket to the moon, flying an airplane, running an aircraft carrier, running a nuke plant, things like that, where you're trying to control every possible variable and just make everything as standardized as possible, but still ultimately most of the variables are known. There's no surprises. Complex problem is like raising a child. And I'm sure many of you have children, and I'm going to go into that in a bit more detail in a second. So in that cake world of simple, you follow the recipe. You standardize, right? When you buy a cake from Dufflet or some other place, believe me, they're not every day winging it, you know? It's exactly the same every single time, right? When you go into McDonald's, their fries are always cooked for the same amount of time, right? I mean, it's absolutely standardized. It is reproducible. No expertise is required, but it helps. I mean, the more you do, the better you get at it, and all variables are known. There's no surprises when you bake a cake. Are there parts of healthcare that are like that? Absolutely. Medical device reprocessing. You kind of want the people down there to be doing the same thing every day. You don't want to get a scalpel that somebody just wiped off on their pants and put it back in the tray, right? You want to know that it went through all the parameters, that everything's been measured, and it's exactly the same every single time. So the other caveat I will say here is often when I talk about complexity, people get upset and they say, but there's stuff that need to be standardized. Yes, there is. So we don't have to get upset today. I totally acknowledge that there's things there that we do need to standardize, just not all of them. In the complicated world, flying an airplane, sending a rocket to the moon, it's obviously a lot more complicated. You've got formulas, you've got calculations. Now experience really matters, right? You don't just hop into the cockpit of an Airbus and fly it, right? There's a lot of training and experience that's required, but you can still separate the parts and coordinate. This is the world where checklists come from. Breaking it down and making sure you're not missing anything and standardizing things as much as humanly possible. I once had an experience on an airplane flying back from Vancouver that I won't go into details, but I wrote about it on Suzanne Gordon's blog about sitting. I actually got put in the jump seat of the cockpit while they were preparing the plane because my seat wasn't ready and they hadn't closed the door yet. The first comment from the trolls on the internet is that this story is impossible because you're not allowed in the cockpit. You are allowed in the cockpit until they close the door. So anyway, I was in there watching them go through their checklist, and it was remarkable the degree of standardization that they were doing there. You separate into parts, you coordinate, and almost all your variables are known. This is a world that we've been told over and over again healthcare needs to learn from. And we do. Don't get me wrong. There are multiple areas in healthcare where we are not standardized and we should be. Operations. I'm not a surgeon, but let's say, for example, our organization does a lot of surgeries and the same sort of problem over and over again, knees and hips, for example. You kind of want to have that run like a well-oiled machine. You don't want to turn around the operating room differently every time. You don't want to have surgeons saying, well, actually, I'm going to take out the hip joint through the nose today because I feel like it. You want it all done exactly the same way, as much as possible. So strategies for these two types of problems: you follow the recipe, you have explicit plans, and then you act. So you plan it out ahead of time and then you act. And you're forcing convergence. You want everybody to do it the same way as much as possible. You eliminate contradictions, you look for agreement, you limit the type of action, and you specify paths and policies. This probably feels very comfortable to everybody in the room. This is the world that we live in healthcare, or at least that we're trying to create in healthcare. Raising children. How many of you have kids? Is it a checklist kind of thing? Like, went to ballet lesson, check. Ate healthy, gluten-free food for breakfast, check, right? There's no role for formulae when you're raising children. No guarantee of repeat success. I always tell, I have 2 teenage daughters, and I always tell my older one that children are like pancakes. The first one's a throwaway, and then you get good at it on the second one. But like, those of you who have more than one child know they're completely different. You can't treat child A the same as child B. Expertise helps, but it's not sufficient. Relationships are absolutely key. That's where the money is. In complex problems, the interaction between the different components of the system, that's where the money is. You can't separate the parts. You can't say, well, because my child wears fashionable clothes, they will succeed. Right? Whereas for baking a cake, you can actually separate the parts like that. There's unknown variables, and as I said, each child is completely unique. Are there parts of healthcare that look like this? Counseling. I doubt that psychiatrists, Brian, you can answer this question. I doubt that psychiatrists are following a checklist. Made patient cry, check. Talked about mother issues, check. Right? It's a very, yeah, maybe you do, I don't know. It's a very iterative, figure it out as you go, extremely relationship-based component. There are parts of healthcare that look like this. There are parts of leadership teams that look like this. Even in the business world, there are things that look like this. We can't ignore this. We ignore it at our peril, because we're gonna make problems if we try to think of this like a linear thing. So as leaders, you have kind of 2 choices. Now I realize I've sort of presented this as binary. It's not binary, it's this infinite options in front of you. But you can kind of ignore the complexity and just drive it. So think of the surgical checklist. Okay, the dynamics in the operating room, for those of you who are familiar with the operating room, that there's a lot of very significant cultural issues in there. Power dynamics, behaviors, all sorts of stuff that are built in the operating room. But we can try to simplify that and just say, do a checklist. Or you can say, wow, there's a lot of relationship issues here. Checklist needs to come a bit later. We're going to work on that relationship bit first to see where we want to go. So you can either minimize or you can kind of embrace the complexity. I'm sure you've all read this Health Canada best practice document. So, I'm glad you found it funny. I'm always afraid someone's going to go, oh my God, does that exist? I should totally read that. It's funny because it's absolutely nonsensical. How would you possibly know how could there be one way of raising your children? If you go to Indigo right now and look at 2 books side by side on raising kids, I can guarantee you can find books that directly contradict each other. And they're both right. So in the world of complexity, this can't exist. So what is your strategy for complex problems? You kind of figure it out as you go along. And those of you who have raised children know exactly what I'm talking about. It's an incredibly iterative trial and error, figuring out what's going to work. But when you start seeing something that's working, you start moving in that direction. You can have paradoxes where what works for you won't work for you. My younger daughter is very, very driven in school. She got a 98% on her midterm exam. And my response to her was, dude, where's my extra 2%? And she thought that was hilarious, because that's our relationship. If I said that to my other daughter, she'd be horrified, right? And I'm sure some of you, when you heard me say that, are like, whoa, what kind of, taskmaster are you? She knows that I'm just happy that she's well-adjusted and doing well in university. She knows I actually don't care about her marks. But you can imagine that wouldn't work for everybody. We develop these so-called generative relationships where when you start working with people, you come up with ideas that nobody's thought of because you've only had your ideas in your head. And when you start to work as a group, you start to create novel solutions. There's no one big fix. You nibble away at the problem. So there's multiple things you're doing to try to make it better. Sounds kind of chaotic, but it isn't. All of these things are kind of I would say there's sort of a box around them, which are called so-called simple rules. And then, as I mentioned, you build on what grows. So simple rules for raising children. In a complex problem, you're looking for these basic principles that everybody agrees with. Simple rules for raising kids: love them, feed them. As soon as I start telling you how to feed them, we start to fall apart. Some of you might be vegan, some of you might be vegetarian, whatever. Some sort of clothing because it's cold, some sort of socialization, etc. But it's at a very high level. So in complex problems, you deal with these overarching principles at a high level. So this is an introduction into the work that we've been doing called Frontline Ownership. And Frontline Ownership is kind of exactly what it sounds. We work with teams to help them tackle complex problems by not ignoring complexity, but getting right in there and working with them, working with the relationships, etc., to find our way forward. It's a combination of an approach called positive deviance, where we're looking for people that have already thought of interesting ways forward that are working, and using facilitation techniques called liberating structures. So you can go to liberatingstructures.com if you want to see what I'm talking about there. And we have used these in multiple parts of the world, working on difficult healthcare problems. So what are some of our principles? And then I'm going to tell you a bunch of stories that hopefully will kind of drive this home. We accept the complexity. We know walking into a place that we will have no idea how to fix the problem. And this happens to us over and over again, that it almost becomes a joke. No clue what's going on here, no idea how to fix the problem, but we're not the ones who are going to come up with the solutions. You are. The people we're working with are going to come up with the solutions, not us. We work with willing participants. So you know all those meetings where you volunteer people to go to them and they sit there rolling their eyes, or they eventually stop coming to the meeting? Maybe we should let those people, give them a break and let them go. Maybe we should invite people who are interested. Leah and I did a lot of work at UHN regarding end-of-life care. And we sent out invitations to all 16,000 people at UHN, and whoever showed up, showed up. And it was amazing the conversations you had. You'd have somebody from finance who was there because their mother had a horrible death in hospital and they wanted to talk about it. They had an opinion. It is amazing how you can move forward when you work with people who actually want to be in the room. There's no right way to spread change, and we'll talk about that a little bit. Some of our work in Ireland, in one of our hospitals in Ireland, all the change happened in the hospital cafeteria. And they had this whole thing designed around how they were going to spread change, and it involved the cafeteria. I can't come to Mount Sinai and go, okay, cool, food court, everything's going to happen there. It's not the same setting. It worked in Ireland, doesn't mean it's going to work here. It doesn't mean it's going to work in the hospital next door to the hospital we worked at in Ireland either. We make the invisible visible. So if there's an elephant in the room, we're going to talk about it. Leah and I once gave a session at St. Mike's where they invited housekeeping staff and nurses from a particular program. And they were seated in rows like this. So when the nurses came into the room, did they sit in front of the housekeepers or behind them? They sat in front of them. Did the two groups intermingle? No. Where were the doctors? Not there. Bingo. You know, or if they were there, they'd be at the side on their phone, right? And Lee and I actually brought this up at U of T once and really upset a doctor in the audience who was at the side on his phone. But the point is that these are behaviors that we have every day, and we actually talk about them. We don't judge, we just talk about them. Why is it that this is happening? We invite the unusual suspects. So as I mentioned, anybody who's interested can get involved in this, and I'll tell you some stories about that. Go slow to go fast. I'll tell you a story about that in Ireland. Basically, the concept there is, you know how we always have a timeline and we're driving and driving and driving? Sometimes you need to let people wrap their heads around things and figure out what it's going to be, and then they can start moving forward. If you push them too hard, they just lose interest and your program falls apart. Nothing about me without me. That's one we hear a lot of in healthcare these days, usually around involving patients. If you're there slamming the doctors in a meeting and there's no doctor, we shouldn't talk about it. We need to bring a doctor next time to have the conversation. Act your way into a new way of thinking is sort of the concept of social proof. When some of you who watch this today may be intrigued by this, but you're going to go back into your normal work environment, and your work environment's going to probably chafe with the approaches that I'm talking about. Well, you could try some things though, and it may be as you try them, you start to see, actually this is working, and that allows you to move forward. I teach at U of T's NEAL program, which is New Emerging Academic Leaders, on this complexity science work, and there was a cardiovascular surgeon from St. Mike's who heard me, who used some of my techniques the next day working with nursing staff, and he emailed me and said, oh my God, I have never seen that kind of engagement. People were so excited. Like, what do I do now? And I'm like, yeah, welcome to the iterative, uncomfortable world of complexity. Now we can start to figure out what you're going to do next. Encourage divergent thinking. If I have a problem with your program, you want to talk to me. And that's really important. In a simple, complicated world, you can try to shut me down. But in a complex world, you want to hear from everybody. And you want to spin that around and around until you figure out a way forward. The path for improvement is rarely linear. How many of you have had the experience of you've got a goal, and you're working towards that goal, and then by the time you get to the goal's over here, right? Things are changing constantly. And so you're going to keep shifting your approach as you get closer to your goal, because your goal is also shifting. The concept of simple rules again, and I'll tell you about those in some of my examples. And we want ownership, not buy-in. Buy-in is a word that is ubiquitous in healthcare, and I'm happy to report Forbes magazine puts buy-in at its number 2 top stupid business terms. Because this is what buy-in means. You've got a problem, you know what you want to fix, you've talked about your options, and then you bring those to people and we say, we want you to buy into the approach that we figured out. It annoys people. It's like, why didn't you talk to me before? I have opinions, but you never heard my opinions. I love this quote from a business professor at USC Marshall School of Business. Asking for someone's buy-in says, I have an idea. I didn't involve you because I didn't value you enough to discuss it with you. I want you to embrace it as if you were in on it from the beginning, because that would make me feel really good. That's buy-in. So if you take one thing away from my talk, replace the word buy-in with ownership or investment. So what does this look like? You've identified a problem. Let's say it's we have a terrible safety record. Right off the bat, you start talking to frontline employees to figure out, let's understand what this is so that we can develop a shared outcome. The more that I'm invested in this, the more I'm going to follow it along to the end, because my idea is in there. Then you're going to come up with options, you're going to come up with choices, and you're engaging the whole time. This feels like a lot of work. It is, but this is a good example of going slow to go fast. If you do your work in the beginning, the rest of it you sail through. So how is what we do different from sharing best practices? In Frontline Ownership, we don't ignore best practice documents, right? There are best practice documents out there for how to prevent central line infections, for how to prevent pressure ulcers, for how to help decrease patient falls. They exist, but how these are being implemented changes dramatically depending where we work, because we're working with the people who come up with the ideas. So in Frontline Ownership, the plan you're going to come up with is sensitive to your little area. In sharing best practices, what worked at the University of Michigan should work here. Our winning approaches come from those who actually do the work. And sharing best practices, they come from the experts. Approaches are spread in many ways in Frontline Ownership. In sharing best practices, it tends to be top-down. And in our experience, the work that we do tends to be sustained. And in sharing best practices, it tends to be a flash in the pan. How many of you have experienced, you're being accredited this year, big increase, and then 2 days later, you're no longer doing that thing, whatever it was. So this is a really key slide, and you can see on the left-hand side it's about ownership, and on the right-hand side it's about buy-in. So these are the places we've worked. We've done a lot of work in North America, a lot of work across Canada, in Maryland and upstate New York, work in New Zealand as well as Ireland, and also I did some work in Sweden. And they're all different projects for different patient safety concerns, and they all, although we used a frontline ownership approach, you can imagine the solutions they came up with were very, very different. So let me talk first about hand hygiene. We cut our teeth on this approach at UHN with our hand hygiene program, and you can see we had a nice little correlation between washing our hands more and actually decreasing MRSA infections. Now, I told you in the beginning, we did not do this well. We failed at everything we tried. It just didn't work. But the difference here was that early on, the people who came up with the ideas were all from infection control, and then we would push them on people. What we started doing was saying, we need to improve our hand hygiene. We all agree, but we don't know how to fix it. So we're going to throw it to you. The role of the senior team here, by the way, was to keep hand hygiene on the front burner week, month, year after year, and to speak to the rest of their reports around what are they doing for hand hygiene, but not to tell them how to fix it. Their job was to push the boulders out of the way. One story here, this is Olga. Olga was a nurse manager on orthopedics at the Western. She, turns out, was a hand hygiene zealot. Now, I would never know that because in the old days, I never would have asked her, because it was me, always about me, not about everybody I'm trying to influence. And so Olga got the message that hand hygiene was important. Her director and her VP were telling her hand hygiene was important, but she didn't know how to fix it. So she did what was within her control. Every morning when the orthopods would round, she brought a bottle of alcohol gel with her, and she washed their hands for them. They would all stand and put their hands out. She'd pump the alcohol gel, she'd rub the gel on their hands, and she would do this day after day. And it became a joke where they'd put their hands out in every room and everybody would laugh. And it fit with her relationship with the orthopedic surgeons. So she did that, and then it led to one of the orthopods questioning our data because everybody seemed to be cleaning their hands. We invited him to audit with us. In the past, I would have fought with him and told him our data are sound. But now, I'm like, by all means, please come and audit with us. He audited with us and found out nobody except the surgeons were washing their hands. You don't hear that phrase very often, by the way. Nobody but the surgeons are washing their hands. So he became a big supporter of hand hygiene. Fast forward multiple months later, and they have the best hand hygiene rates at UHN. And it started with Olga washing the doctor's hands. You can see how that's so relationship-based, right? She did something that fit with her relationship. This little flip tab has a fun story. So Leah was very involved in this story. We had been trying to get housekeeping services to put those flip tabs at the top of our alcohol gel dispensers for years. The idea, if the dispenser's empty, you flip it up and then people know to put a new cartridge in. This grew out of Marketplace did a little program called Dirty Doctors when they went around with hidden cameras in hospitals and showed that nobody was cleaning their hands. And one of the big things was the dispensers were always empty. We had the same problem at UHN. There was one weekend I was on call for ID and I walked through the ICU at the Western with a big cart full of alcohol gel dispensers and made a big production out of putting new ones in because it wasn't happening. So we tried to get people to install these. Nobody wanted to install them because they weren't sure what they meant. They weren't sure, like, they were too small, etc. So we gave up. Leah starts engaging healthcare workers at Princess Margaret Hospital and uses one of the techniques that I'm going to do in a second to ask them, how they might make things better. One of their ideas was the flip tabs. Idea came from them, not from us. We said, great, we'll get you the flip tabs, you do with it what you want. They installed the flip tabs at Princess Margaret. We had a lovely story in UHN News that talked about the flip tabs at PMH. Those of you who know anything about UHN know that our sites have a modest competitive nature between each other. Modest, only modest. So all the other sites started installing these as well. Fast forward a couple months later, every dispenser has these flip tabs, and the dispensers are no longer empty. Here's the key thing. I don't think anybody uses the flip tabs. It's not about the flip tabs. It's about the fact that they were engaged. We could have published a paper, and you can publish anything in the infection control literature. We could have published a paper on this, flip tabs associated with remarkable hand hygiene improvement, and you would bring that to your hospital. People go, what the hell's a flip tab? I'm not using a flip, and you would start all over again. These are data from New Zealand. So I went down to New Zealand to do some work with Hand Hygiene New Zealand, which is a national program. They were struggling. They had hired IHI to help them with hand hygiene, but PDSA cycles were not resonating with their frontline staff, and they weren't really resonating with the infection control people who were trying to lead them. So they loved the idea of frontline ownership because New Zealand has a lot of regional variation. If you're on the South Island, they don't want to hear about the North Island, and nobody wants to hear about Auckland. It's kind of like, Auckland's kind of like the Toronto of New Zealand, right? So they loved the idea that they could have simple rules, and we did at UHN as well, right? Have to use the same alcohol gel, we're all auditing the same way, it has to be at point of care, but after that, we let you do whatever you wanted. They did the same thing, and they were able to finally see very significant improvement. And it's very gratifying for me to go on to Hand Hygiene New Zealand's website and hear about how Frontline Ownership has transformed how they do patient safety in that country, because they've now realized having the simple rules and allowing variability was really important. This is a project we did in upstate New York called Bordering on Zero. We worked with 13 hospitals there. Our sponsor was actually Blue Cross Blue Shield. We had a dramatic reduction in falls in the work that we were doing for free. It didn't cost any money. It was just the cost of us helping them. But otherwise than that, the things they did were all pretty straightforward. So how did they do that? Well, here's an example. One of the liberating structures we used is called TRIZ. We would go into a ward and ask people the following question. How would you ensure that every patient on your ward falls and breaks a hip, or ideally gets a subdural hematoma? How would you make that a reality? What would you do? Just yell out a couple ideas. Leave no side rails. Wet floors. Electrical cords on the floor. Poor lighting. High beds. You got it. Right? Don't answer call bells. Or my personal favorite at Bridgepoint when we did this was place the call bell exactly 2 inches too far from their... Right? Take away all the walking aids, et cetera, et cetera. So we did that in multiple hospitals and engaged staff that way. The second part of that is, which of these things are we currently doing? And the answer is the majority. And the last part is there anything on this list that's within your power today that you could start fixing? So we're not ignoring that there's best practices out there for falls prevention, but we're engaging you to figure out the road you want to take. Whoops, why does it do that? There we go. So different wards, different approaches for preventing falls. The one in the far left-hand corner, different socks. They realized that the no-slip socks they were giving their patients were all extra large, and people were tripping over the no-slip socks. So they had different sizes with the treads all the way around. So however they were put on, they still had grip. They could climb walls and stuff with them. Another one, they found most of their falls were happening at 6 or like 5:30 in the morning because that's when blood draws were happening. So if you go onto a geriatric floor, wake people up, draw the blood, the next thing they're going to want to do is go to the bathroom. And there's no staff at that time to help them. So when we asked them why they had the blood draw at that time, they said, well, the doctors want it. But there were no doctors in the room. We invited the doctors back. The doctors had no idea that blood draws were associated with falls. And so we changed the blood draw time. So one place built falls into bedside report, so the patient heard about it. They were talking to patients. On psychogeriatrics, they gave people busy aprons. Now, these were not any sort of restraint. They were just a vest that had buttons and things they could play with, and it stopped them from wanting to get out of bed. Staying with patients in the bathroom. Fall monitors. There was one hospital that had purchased falls monitors, but they were so annoying at night, they would turn them off. Which kind of defeats the purpose. So their strategy was to turn them back on. Now, you can imagine, as people have been heard and they've been listened to and they start to see their ideas moving forward, do you think it's about the socks? Because it's not about the thing. It's the fact that people were engaged in the actual creation of different solutions. Brief story from Ireland. How many of you have heard of the Hello, My Name Is campaign? It's very much sort of a UK kind of thing. It was created by a doctor named Kate Granger who was dying of cancer, and she noticed none of her healthcare providers were giving them their name when they would come and see her. And she got very offended by this, and she created this campaign where people can voluntarily wear a little badge that says, "Hello, my name is." We had about 3 or 4 nurses who worked, I believe they were in the OR or the ICU. Do you remember, Leah, which one it was? It was Emerge, nurses in Emerge who wanted to start this campaign. And they came to us and said, "Can you come and talk to leadership in the hospital to see if we can get this thing adopted for our hospital?" And we said, "No, we're not going to do that. Why don't you start wearing the badges? Why don't you put signs up in the canteen, or the cafeteria? Why don't you go viral with this? So if anybody asks you what your badge is, tell them about it. So make the information known, but don't force people to do it." A few more people signed up, Some people didn't want to sign up. That was fine. It was entirely their choice. 9 months after our project ended, all 1,600 employees at the hospital were wearing these badges, and they all did it voluntarily. That's that going slow to go fast concept. You give people time to wrap their heads around it and see if they want to move forward with it. And it was just a wonderful example of that. Well, Leah and I both have badges like that too, mine keeps falling off, so I don't wear it anymore, but I was wearing it for a while. The key point in this work is that there's a tension between standardization and allowing local variability, and that's part of the fun. When you engage people, you have conversations around what can we allow local variability and what has to be standardized. So at UHN, we use one alcohol gel product. We're not going to let 20 different products come into the organization. That's going to be expensive. So you set those simple rules, and then you allow variability elsewhere. So in summary, you got to have the conversations around standardization versus variability. Simple rules are incredibly important. And you're always looking for ownership and investment. Remove buy-in from your vocabulary, just throw it away, and think about, how do I get you so that we can co-create this? And different projects is going to have different levels of engagement, right? And obviously for some things, if you've got a program on something which is incredibly important and has to be done within the next 2 months, you may have limited time for engagement, but there's still, make as much time as you can to talk to people about it. And my final point is that it's not about the tools in complex problems, it's about the relationships. So when we've brought checklists in and they haven't worked, it's not that checklists are bad. Love checklists. Checklists are fantastic. They have to be in the right context where you've got a culture that is willing to accept the checklist. And if you don't do that, it's just another tool. I'd like to thank a lot of people here for this work. I mentioned Leah already up at the top there. We have a small team in Toronto who helped lead some of these projects. We have a Frontline Ownership user group, some in Toronto, New Zealand, the US, and Ireland. And I'd really like to thank Schulich for their support for me. Components of this form our healthcare leadership development program at Schulich. We approach it from that complexity angle to help people figure out their way forward. And in particular, I've mentioned Brenda Zimmerman before. This work really grew out of her work, and I am very thankful to have been able to work with her. We'll leave it there. Happy to answer any questions you might have.
So if you have any questions, just put your hand up and I will bring the mic to you. Do we have any questions?
Really? No questions? There we go. We got a question.
There we go.
That was great, thank you. Can you talk a little bit about sustainability?
Yeah. So sustainability is really the key thing in all of this work, right? You have this big flash. So when Leah and I do this work, the hope is that when we're done, we're out of a job. They no longer need us anymore. So Ireland, to give you a good example, we were there for 9 months. We had 4 different trips to Ireland. And since we've left, they have developed a Frontline Ownership users group, which now encompasses the entire country. They have built Frontline Ownership into all of their quality and safety programs. The hospital we were working with has moved on with a number of projects that people never felt they were able to do. And we're not there. Now, believe me, we want to be there because we loved working with them, but it worked. In New Zealand, I really want to be there too. Any of you traveled to New Zealand? Amazing place. I'm always trying to get myself invited back there again. But the truth is, they're just zooming ahead with all this stuff, and we're not there. So these projects can be sustained, and I would say the majority of them have been to some degree. Where we get into trouble is if you get leadership changes, team changes, et cetera, et cetera. If you have a very omnipresent top-down approach that a new leader brings in or something like that, this allowing for local variability kind of gets squelched. And so we certainly have had circumstances where that has happened. I didn't present all of our projects. We've had other projects as well, but in general, they've been very durable after we've left. Yes, another question here.
How would you see this work, I guess, being transferable to patient engagement, patient responsibility for self-care, getting at the primary?
Yeah, it certainly is transferable. It's a matter of having the conversations with people that are doing that work to figure out how you would do it. But fundamentally, the concept of patient empowerment and patient ownership and patient investment in their care is something we would want. We had a very odd experience in one of our hospitals in New York where the staff misinterpreted us. We had suggested you need to include more patients in this work. And they interpreted that as we should go to the guy who always falls in our unit and do trizz with him. So, Mr. Smith, how do we ensure that you always fall? And he's like, what? And then he gave them a list of things he should do. And it's funny, it actually worked. It started a conversation. They started to realize why this gentleman was always falling. He was deeply proud. He wanted to be autonomous. And he realized as he was saying these things that he was contributing to his falls. The staff learned something. And the last I heard of this story was he was admitted and never falled once. And as he left, he said, hey guys, I didn't fall this time. I think there's a massive role to use these kinds of approaches in engaging our patients. In the different projects we did, some engaged more, some engaged less. We were kind of at the mercy of who we were working with. But we have no doubt that there's a big future in this for that particular population. A couple more on the back there.
Hi, Michael. Excellent talk. Thank you. So you alluded to, in your experience with falls reduction,
Yep.
having had huge gains in terms of reducing falls without really having to invest much money into those interventions or
Yep.
anything, really.
Yeah.
Have you done any formal cost analyses with these groups to see what the investment has been and what the return has been? Because it seems to me like these approaches, one of their advantages is that they're cheap to do and they're sustainable.
Yeah, you know, we haven't gotten there yet. I think one of our challenges is you can probably tell that what I'm talking about is a bit countercultural in healthcare. And so we need to have a few more places that want to try these things out for us to start being able to get in there and actually really measuring them. There is one big New England Journal study that was looking at positive deviance in the VA healthcare system in the US. It wasn't a formal cost analysis, but they had a dramatic reduction in MRSA infections in their hospitals using positive deviance, which didn't cost them anything. And so when you've got an intervention which costs nothing, except for the price of having us come and teach you how to do trizz and things, you can imagine the cost analysis should be pretty easy, but we haven't gotten there yet. Yeah, you telling me to do it? Okay, oh yeah, we'll do that. There's some hands up at the back there. Oh yeah.
Hi. I was just wondering, at the end you were talking about relationships and culture, and it sounded like the culture at that institution needs to be open to change, but what if you have resistance? How do you overcome that?
Yep. That's very hard. And I mean, what Leah and I have learned is that You can have an organization that may be quite hostile, but there's pockets that aren't. And so we would work with the people who want to work with us. And so there may be areas where they're quite open to trying something like this. And the hope is, as those people get social proof and start to realize this will work, they can start to bring along others. And you can imagine being influenced by a peer is way more valuable and way more potent than trying to be influenced by a leader who you don't know very well. And so we have had circumstances like that. We've had organizations we've worked with where this work is almost clandestine, where it's being hidden. They're having like almost sort of secret meetings to decide how they want to do things. But it is very hard. You do need organizations that have at least a willingness to realize that a lot of their challenges are due to relationships. And I think we all know that. Right? If I was to ask you what are some of the biggest challenges, somebody's going to say culture, somebody's going to say doctors, and usually doctors and culture together in the same sentence. And then we educate them. And that's not the solution, right? So I think that there is willingness and openness to try these things, but it may very well be in pockets. And if the organization is truly not interested, then it's very hard to do it.
Oh, you had the same question. Okay.
Okay. A couple more questions coming along here.
Thanks, Michael. Great talk. I have a question about data and the role of that in supporting some of the cultural change. So I know with hand hygiene, oftentimes showing people data isn't going to change their behavior. But I was wondering if you could comment on how data can be used to help support the behavior change.
Thank you, Jess. It's like I planted that question in the audience because I forgot to mention data. So thank you for that. Data supports this work like any other quality improvement work. The key difference is we're going to work with you to figure out what data matters to you. So let me give you a real life example. If I tell you your falls rate is 10 per 10,000 patient days, I have no idea what that means. I have no idea if that's good or bad. If I show you a graph, it only matters to me if the graph matters to you. So we worked with one ward in New York. Their approach to falls data was they asked the staff, how did they want to see these data? They drew a lovely tree on the side of the nursing station and put a bunch of leaves on the ground below the tree. And every day they didn't have a fall, they put a leaf on the tree. They got to 150 something leaves, and then a patient fell, and they brought all the leaves back down to the ground again. And you can imagine that really meant something to people. You got to the point where they were like practically wrapping people in bubble wrap so they wouldn't fall because they had all the trees up there, they had all the leaves up there. Now here's the cool thing. I love that story. I love that image. If I bring that to general medicine at Toronto General, they will tell me it's a stupid idea. That's the reality because it needs to come from them. So we tell the stories, but we allow people to figure out what's going to work for them. So the data absolutely matter. In the background, we're churning out all the stats and everything that everybody else, I was able to show some of those on the graphs, but we know that may not influence you. And so we're approaching it very much from this relationship perspective and allowing you to figure out what data matter for you. And sometimes it's a bit of both, right? So that ward that had the tree, believe me, we also were calculating their rate per 10,000 patient days at the same time. It's just that's not what they were seeing when they were on the ward.
Well, I don't really, my voice carries very well. But having said all of that, you make reference, I think, Michael, to you may go into an organization, and as you mentioned before, you may have a few pockets you're going to sort of focus in on.
Yeah.
And one of the things I often mention over my last 15 years of doing medicine is I've learned most of what I've done and improved by how I interact and watch how people interact.
Yeah.
And the question arises, if I have like 5,000 people in an organization and you want to create change and you're looking for pockets, maybe it was done in earlier studies. My first reaction more from a psychological bent would be that a lot of your positivity comes from basic psychological events like mob psychology, peer pressure, reward systems. So does anybody ever go and say, hey, look, we have some effective changes. 90% of the population here doesn't want to affect change. So instead of skipping just to the 10%, I would pull back and say, Why are they afraid of change? Maybe we need to look at this, and then if we know why, we can speak to them about it, and they would be more positive with change. Because some of the reasons are, like, a lot of doctors won't affect change. Why? They don't want to get sued. Why? They already work too hard. You know, why? They may have diminishment. Or nurses may like more structure, and that's going to create a problem. So I wonder, maybe in preliminary studies, you ever pull it back and say, let's find out why people don't want change in general in this situation?
Yeah, we've never done that in a systematic way. What we've done is we've tended to work with the people, as I said early on, who want to work with us. What we find is over time, those people that are kind of sitting on the fence come along for the ride. They start to get engaged. And when we have talked to them, we've heard things like, when I've voiced concerns about how we're doing something, I've been shut down in the past. So I don't talk about it anymore. Or we had one housekeeper who told us when we started doing this work, she had worked for 25 years at UHN, and this work gave her the permission to think. Because before, she was just told what to do. Nobody ever asked her her opinion. And people who work in safety will tell you that the housekeeping staff actually have a huge view of what's going on, but we rarely ever talk to them. So we've certainly heard snippets of that, but we haven't done it in a very systematic way. In my experience leading doctors through the MAC over the last 6 years at UHN, a lot of the disengagement is simply where people just don't want to listen to us. And so after a while, you just kind of quit talking. But as you know with doctors, we quit talking until we get really pissed off, and then it's like this full court press at you. I would love to avoid that and actually have the dialogue earlier on. So I think there's a lot more work that could be done there, but it is interesting. A lot of the people who are disengaged, it's not really because they don't care. That was something I learned very early on. I used to say doctors didn't care about hand washing. I've been quoted saying that many times. It's actually not true. What doctors don't care about is having some dude come and talk to them about hand washing and get angry with them. That they don't like.
With that, thank you very much, Michael Gardam.
Thank you.
So our next Breakfast with the Chiefs is November 29th with Dr. Michael Apgon, President and CEO of Sick Kids Hospital. Thank you and have a wonderful morning.